it, and if I can correct it, that's always the best solution. But if you can't correct it, what's my compromise to go in? Or do you have any other?
Yeah, I think if you have medial instability and insufficiency, I cannot tolerate it all, because they won't be happy patients, and their data is with medial instability they cannot tolerate. If we have a lateral insufficiency, I tolerate it more, because the kinematics are more movement on the lateral side, and patients tolerate a slight insufficiency lateral, and they can tolerate it. But if you have a medial collateral insufficiency, they don't do it. So my recommendation would be, if you have a medial insufficiency, go for a higher constraint. If you have a lateral, you might tolerate it.
Sebastian, what's your cut? Is it? I know it's hard to say like a fixed number, but how much medial lucency do you tolerate?
I agree very little. I think knees want a stable medial side to function well, and some of the cases I've unfortunately been a part of where there's been damage to the ligaments intraop, the medial collateral ligament, it's usually not a fixable problem. Usually the injury is at the level of the joint, sort of right through the MCL, not really at the origin or attachment. And so in those cases, you have to increase the constraint. In terms of, how much, I would say, in flexion, if you're flexing the knee with the trials and you see that the medial side is lifting off, that there's no contact between the poly and the femoral component, that's definitely an issue and needs higher constraint. And in extension, I don't have a good number, but if you're having more than 4 or 5 millimeters for sure, you would need a higher constraint.